Let us get started. Welcome everyone to this virtual roundtable discussion with Laurie Garrett. What a privilege to have her with us. My name is Jaime Sepulveda. I'm the Executive Director of the Institute for Global Health Sciences. We have organized this in conjunction with the Bay Area Global Health Alliance. I would like to recognize my friends Mary Pittman, who's the chair of the board of the Bay Area Global Health Alliance, and Sarah Anderson, who's the CEO, Executive Director of the Alliance, and also recognize Jeremy Alberga from my team, who together with Sarah has been working so hard in making this happen. So we have a great group of panelists and our main speaker, of course, and I will introduce them in a moment. But let me first go through one housekeeping reminder. This is a two-part event. We will have a fireside chat that my colleague Paul Wesson will moderate, and Laurie Garrett will be in the fire chat person, and then we will open to a roundtable with great panelists, and finally we will open for a Q&A session. To the audience, please pose your questions in the Q&A section, and we will curate the main questions to Laurie. I don't think Laurie needs much of an introduction. Frankly, she's so well known to all of us. But just as a reminder, she is the author of many books and reports in foreign affairs and foreign policy. The book that brought her to fame is The Coming Plague: Newly Emerging Diseases in a World Out of Balance and Betrayal of Trust. Laurie is also a columnist for foreign policy and science contributor for MSNBC. I met Laurie many years ago, more than I dare to mention. She was a contributor to a book that we put together called AIDS Prevention Through Education. And she wrote a magnificent chapter called AIDS, Government, and the Press. That was back in 1992. So that's how long ago we go with Laurie. Laurie is the only science writer that has received the 3 Ps: the Pulitzer Prize, the Peabody Prize, and the Polk Prize. So it is indeed an enormous privilege to have her with us today. Thank you, Laurie. Let me introduce the panelists as well. My friend Larry Brilliant, who's a physician and epidemiologist. He's the CEO of Pandefense Advisory and also a senior counselor at the Skoll Foundation and a CNN medical analyst. And he does credit to his last name. He's so brilliant. My dear friend Jonna Mazet, she's the vice provost at UC Davis. She is the chancellor's leadership professor of epidemiology and disease ecology, and I would say the top expert in One Health. We also have Thu Do, who is the Director of Medical Affairs, Global Patient Solutions in Gilead Sciences. And finally, my colleague Paul Wesson, who will be the moderator of the fire chat. He's an assistant professor in epidemiology and biostatistics at UCSF. And let me pass the microphone and the floor to Paul.
Great. Thank you so much, Jaime. Laurie, it's such a pleasure to be able to speak with you now in this forum. I remember reading The Coming Plague back in the mid-aughts when I was first learning about epidemiology and getting really excited about epidemiology as a possible career path. Clearly, I followed that and actually had the book here in my home with me and was just browsing through it the other night and going over how much I vigorously highlighted all throughout the book. So it's really a pleasure to be able to speak with you now. And so starting on that note, when it comes to considering pandemics and considering how to prepare for future pandemics, COVID-19 was not our first rodeo, if you will, when it comes to pandemics. We have a long history of facing emerging infectious diseases. You literally wrote the book on our long history of that and how biological, social, and political forces influence and augment transmission risk. And I, of course, come from a field where we have scientific methods developed to really tackle these threats in real time and have a solid understanding of what's driving them and how to stop them. So with that backdrop, the first question I wanted to ask you is why were no, in your opinion and from your perspective, why were no cohorts created for tracking the SARS-CoV-2 virus in vulnerable populations in the United States in 2020 and more so in Seattle after the Seattle cases? Why didn't the CDC hastily set up nursing home and assisted living cohorts for daily monitoring?
Thank you for that question, Paul. And it's a darn good question. And I don't really have a great answer for it because it's a demonstration of unbelievable incompetence and it's a huge failure. Even now, we have very few cohorts of any kind that are executed by CDC or, frankly, even most academic institutions for tracking any aspect of the COVID crisis in a meaningful and useful way. And it's shocking. I mean, this is epidemiology 101. And as you said, the most striking is that we didn't, after we had that nursing home incident outside of Seattle, that we didn't immediately say, every single nursing home, or at least system of nursing homes across the country, had to set up a sentinel cohort for monitoring what was going on and look at the staff as well as the patient population. And, you know, once we also came to appreciate that a lot of staff in nursing homes work in multiple homes because they don't make enough money on one job. So they double decker, triple decker, meaning that if one were a carrier, they could conceivably infect populations in 2 or 3 or 4 nursing homes. And yet, even knowing that, we did not set up cohorts to track these personnel. We still haven't. For the most part, we continue to operate on a fairly blind level when it comes to bottom line epidemiology with this epidemic.
And I guess as a follow-up to that, you know, it's been over 2 years now since COVID really erupted. And as you pointed out, you know, we still don't really have certainly enough cohorts tracking the continued spread of the virus and sequelae. From your perspective, what do you think we would learn or could learn with the implementation of these cohort studies that we don't already know?
Well, of course, you're the biostatistician in the room, so you know, you ought to be asking yourself the question, but I will venture something of a response. Look, back when there was the first great reopening, you know, after our first spring surge in 2020, looking at the fall of 2020, and lots of discussion of what should we do about the schools, the National Teachers Association and other teacher organizations asked me what should be our position on all this. And there again, I was saying we should set up really excellent cohorts. There should be some standardization, perhaps out of CDC or out of a smart academic center, that would design what would a cohort look like that would be really meaningful to give you real-time information. So you're looking at parents, staff, students, and perhaps some community indicator for nearby adjacent to a given school. And you have a small cohort of perhaps 10 people that you're tracking very closely day by day to tell you, these are the canaries in the coal mine. Do we need to lock down the school? Do we need to send all the kids from the 3rd grade home, or whatever it may be? But we've never done that. So from the very beginning, it was an all or nothing. Either all the schools were shut down or all the schools were open. Either everybody was tested every single day or nobody was tested. And so the choices in the context of the schools have consistently been political choices. Very few school systems have made decisions and choices on these very difficult issues that have enormous political and economic consequences based on science and on real science specific to this virus and how it was transmitted. And, you know, a big part of this is recognizing that more than 90% of the transmission is from asymptomatic individuals. So fever checks and all the things that worked in the past and other outbreaks aren't going to help you here. And also recognizing that the individual transmitter, who may again be asymptomatic, it's aerosolized transmission. So if they are in a classroom, the odds that you can eliminate transmission without using a face condom, you know, are close to zero. And so I think that we've missed an enormous opportunity here. And you could do the same thing with sites of employment, with mass transit. Again, imagine if we had for the BART system, for example, cohorts that involved employees of the BART system and perhaps some randomly selected, smartly designed cohort of regular routine travelers. And we might have a much better idea of whether or not there really was significant transmission going on in the BART. And if so, under what circumstances and how could it be mitigated? But again, all these decisions, all these choices, all these plans have been based on some kind of bottom line textbook understanding from past epidemics, not specific to this virus, and on politics and economics. And so not surprisingly, the backlash against them is not scientific. It is politics and economics.
Yeah. And I do want to return to this issue of politics and the interaction of politics and science. I have that keyed up for another question, so we'll get to that in a moment. Continuing with this theme of the sort of specific scientific response, I want to turn now to Operation Warp Speed and ask you how significant a difference do you think it would have made if the FDA approval conditions under Operation Warp Speed had included a demonstration of efficacy in the prevention of infection?
You know, to this day, most people hear a vaccine and they assume that means they have a lowered risk of acquiring infection. And most vaccines, that's true. That's what we aspire to make something that builds your defenses in your immune system to prevent you from being successfully infected. You may have virus enter your body, but it doesn't take hold. There's no infection and there's no threat of an ensuing disease process. That is not the case. What happened was with Operation Warp Speed, the small group of people at the top who made the decisions inside the FDA, inside the drug companies, inside the White House, decided to set the bar much lower, because setting up cohorts, here we go, back to cohorts, to do appropriate clinical study that would answer the question, is the infection rate lower in group A versus group B versus group, and doing so for multiple dosages of a brand new vaccine about which we're not certain what dose is appropriate and so on. You know, the industry argued this would take months and we need something right now. So let's not do that. Let's instead just monitor the hospital and monitor the graveyard, basically. So if we can demonstrate that it doesn't lead to hospitalization, it doesn't lead to death at the same rate, and it's a significantly lower rate, then if it also fits a safety profile, boom, you've got an approved vaccine. What that meant was that we had a vaccine that we could start to go to escalate through the pipeline by the late summer of 2020, an astronomical speed. I mean, phenomenal. And deservedly, everybody gets applauded for it. But it also meant we had made a choice. We will not be able to stop this epidemic with a vaccine because we had not made one that could stop transmission. Unfortunately, then every subsequent policy, both in the Trump administration and the Biden, and in their counterpart administrations around the world, everything has been designed around a pandemic we would somehow miraculously stop with a vaccine that does not prevent transmission.
So I think you raised an excellent point there about the considerations in developing the vaccine or putting sort of delivering the vaccine to market at the time we're in this heightened state of emergency, that we then lowered the threshold of that is normally required of our vaccines, and said that as long as it is safe, as long as it prevents death, and as long as it prevents serious illness and hospitalization, that's good enough. We're in a very different stage of the pandemic today. Do you think that it deserves a re-examination of our threshold of, I guess, what's acceptable for a vaccine at this point? Do we now go back to the drawing table? And
oh, of course it does. But political reality is the money is spent. The money is spent. There are things in the pipeline, products where the designer of said products aspired to a higher target. But we're all locked in now with Moderna and Pfizer, AstraZeneca, the Chinese vaccine, the Sputnik, and a handful of products. And there's no real appetite by any government to spend the kind of money necessary to bring a much better product to the market. So we're going to just keep adding silly boosters that are against a strain that circulated 6 months ago and then encourage people, and it takes 6 months to get them to do it, to get, another boost and another boost in perpetuity. And, this is absolutely asinine. But, it goes to a bigger problem, which is when an epidemic hits, there is this moment when you have to set the aspiration, or you could think of it as the strategic goal. Your strategy has to start with a goal, and the goal has to be clearly understood. If the goal is eliminate human-to-human transmission, bring this epidemic to a halt, then you have to make a vaccine capable of eliminating human-to-human transmission. But the aspiration and strategic goals were never clearly stated, and no two nations seem to have the same ones, and they change all the time. I mean, there was a point in 2021 when New Zealand and Australia thought that by forming a specific COVID-related alliance and limiting all travel by everybody from the outside and sharing goods and whatever between the two of them only, that somehow they could forever be without COVID. Well, it's continued to swirl around the rest of the world. And now we have China, which thinks you see 2 cases, you lock down a city, and that they can do this forever. And you keep wondering how much more economic damage is the Chinese population going to accept? How many more times are all schools and all universities and all businesses and all housing complexes going to get shut down over and over in Shanghai, Beijing, you name it? Well, the strategic goal was set. It's one of the only countries in the world, that really set a strategic goal and has since stuck with it. And that goal is zero COVID. So if you don't set the goal and you don't make a product that matches the goal, surprise, surprise, you're endlessly defeated.
Mm-hmm. And so just to follow up on that one more time, do you really think that that ship has completely sailed, given the, as you mentioned, with these continued boosters, there's more and more of a struggle to get more and more of the vaccinated of the population vaccinated with boosters, and aligning different countries' strategic goals or lack thereof. Would knowledge of potentially more effective products be enough for the broader populace to advocate for the scientific investigation into their efficacy and introduction into the market?
Well, it is interesting that recently Eric Topol from UCSD or Scripps, I guess he is, and a number of his colleagues have published strong statements calling for a nasally administered vaccine. They haven't fundamentally challenged that it would be the current Pfizer or the current Moderna or some already in use formulation, but they believe, look, we have a better chance if we administer through the primary route of exposure and infection, which is the nose. If you were to shift even with the existing products to an oral administration, it's possible we would eliminate shedding, which we know is occurring because we can detect it downstream in wastewater. But so far, there's not the kind of money and serious political attention given to alternatives. And I mean, I think there's quite a lot of people out there arguing that a live attenuated antigen, a live attenuated vaccine, sorry, I'm trying to turn off my phone because it's making noise. Apologies.
No worries.
That a live attenuated, orally administered would have a remarkably better impact than our current crop. But I just don't see, I mean, the GOP has blocked even funds for basic things like administration of testing and equitable access to vaccine and treatments in the United States. We're already drawing in the red on our budgets. A lot of states are way over their heads on their COVID budgets. They're desperate for federal assistance and they're not getting it. So now you're going to say, well, while we're at it, let's put another $10 billion into some other drug company and have them bring another vaccine through a full scale of clinical trials and FDA approval, and then mass production and distribution. I mean, and I think also unstated by officials, but clearly whispered on the sidelines, is a great concern that the already declining level of vaccine acceptance would go down even further if there were a sort of acknowledgement of the shortcomings of the existing vaccines and a call for an altogether, different strategy in terms of the style type of vaccine. We've convinced the world that some great triumph was made with an mRNA product. If we were to now turn around and say, well, you know what, we want to go with a very different form of vaccination, I think we would have a significant problem with the anti-vaxxers. And I would just finally say, the best way to characterize the existing vaccines is that they are medical products. They do nothing for public health. They don't cause a sudden diminution in the number of infected people on the planet. They don't suddenly eliminate the need for vigilance and all the measures that are essential to a pandemic. Rather, they lower the numbers of people that have to be hospitalized and the numbers of people that may die. That's all great, but that's medicine. And that's very much kind of at the individual level. Did Paul get all his boosters, and has it taken with his particular immune system in such a way that when he gets exposed and infected, he has a mild, ailment resolving within 2 or 3 days of staying at home? Or, did Paul have a very different scenario, either because your immune system is stressed for other reasons, or because you never completed your vaccine schedule, or because of fill in the blank? And that's the other problem, because we never have had really good cohorts. We have fill in the blank.
Mm-hmm. Right. And, not taking into account people's varied circumstances, as you pointed out, with the role of prior vaccination or the role of age, the role of other comorbidities, et cetera, et cetera.
Exactly.
So moving on to my next question, and there'll be some interweaving of what we just talked about as well, about political influence as well. But I want to begin with asking, what do we know about the role of social influencers in public responses to vaccination, social distancing, mask wearing, et cetera?
So here I think the medical community needs to show a little humility and say, praise to the sociologists, the psychologists, and the anthropologists out there, because a lot of good science has been done tracking exactly this question. Why are people refusing vaccination, or reluctant, or nervous, or scared? Who do they turn to if it's not their medical provider, if it's not the government, if it's not public health writ large, if it's not Tony Fauci on MSNBC? Who are they turning to advise them and tell them this is or is not safe? This Bill Gates microchip is in it, or this is 100% safe and it will save your life. And there have been exhaustive studies done all over the world. I mean, almost every society of any significant size has had pretty exhaustive research done now that does show that key kinds of influencers have tremendous power in this situation. And if positive influencers do not get ahead of the trolls, if they aren't out there putting out an effective messaging before the message gets sabotaged and taken over by RFK Jr. and so on, then they're constantly playing catch up, and you will see a steady erosion of their capacity to influence the course of public opinion. And unfortunately, for a lot of people in this country, the ship has sailed. And most studies are showing in the United States that we have a rigid, somewhere around, it says that I have signed out. Are you hearing me?
I can hear you, yes.
Okay, a pop-up just came up alarming, telling me I'm not on anymore.
It may just be you and I.
Okay. But if we had an effective way to understand who are counter influencers that really work, we might be in a much better position than we are now. Of course, the one thing I should say in defense of public health efforts on all this is that in every single role playing I was ever in, every war game scenario where we looked at the possibility of a deadly pandemic sweeping over the world, or at least just the United States, going back, 30 years, no one ever imagined that the head of state, the president of the United States, would be the primary source of disinformation.
Yeah. And I guess that's a really great segue into a follow-up question I had. So I think it's no secret that scientists are not the best communicators. You can ask anyone in my family for verification on that one. But I'm wondering, as a science writer, how can the scientific community, or what's your perspective on how the scientific community can better communicate what we know and what we do not know, and also not be drawn into the politicization of a situation? One of my, and maybe that's not even possible, one of my favorite quotes from another writer I follow, Elizabeth Bassani, was that science does not exist in a vacuum, and so sometimes we can't pull apart the political forces or the social forces that are also at play with what we're studying.
Yeah, well, I mean, this problem is far larger than COVID. I mean, this goes back to everything from trying to garner support for the space program by arguing that we should know about Jupiter just because we should know about Jupiter, all the way to how people will react and respond to specific threats, such as anthrax spores in the mail or COVID being coughed in your face at a community meeting. And I think scientists, first of all, your training is to understand that there are no absolutes, that science is a process, that what seems to make sense and be real about how this plant grows in 2020 might prove to be completely wrong with new kinds of research and new tools by 2022. And that doesn't mean the first guy was a liar or an idiot or anything. It just means the process has moved. And in many ways, an epidemic like COVID is a high-speed process. And the learning curve, I mean, this epidemic is unprecedented. Everybody knows this. You've never seen the level of publication and preprints. I mean, I can think of no prior outbreak where I have been reading unrefereed papers by, the stack every single day. And that means that the burden on me is to try and figure out if this is good science or not. But imagine what it means for somebody who doesn't really understand what DNA is. Right. And I think that scientists have a very hard time communicating to people with an understanding that they might not really get what DNA is, but without being a snob about it, without making that person feel little, feel dumb, because they didn't have a good enough education. They didn't have the privilege of learning what is DNA. And to get to the point where scientists can somehow speak about the gray areas, about the evidence weighs this way, but it could be that way. The public, especially when it's scared, wants yes or no. Yes or no. And I think it's just very, very hard. I mean, if you want a textbook of how to do it right, sit down and do some YouTubing of Tony Fauci. But there aren't very many Tony Faucis out there.
Yeah, I think that's such a great point about how science is a process, and I would get frustrated watching movies where it features some scientist, and in a matter of a day he or she figures it out, or there's a quick 30-second montage. Exactly. And so it's such an unrealistic portrayal of what the process actually is, and I think it connects back to your prior point that. Because of this misperception and this feeling that whatever is said is known for certain and is absolute, there is more resistance to then going back and saying, this worked, or this was the case, or our best understanding in this at this time, but the scenario and the situation has evolved, and now with this new information, we now think this, or with this new information, we want to course correct and take us in a different direction to have
Paul,
these updated change games.
I think this is the best example, because very early in the epidemic, based on experience with SARS 2003, I couldn't see any reason why you would wear this outdoors ever. And I felt like the utility of masks was being exaggerated. But of course, at that time, we didn't have cases in the United States that we knew about. And China was not telling us that there was asymptomatic transmission. And we certainly didn't know it was aerosolized yet. And so that as more information came in, and we started to understand that this was the very best tool we had for the mass public to protect itself, then the messaging changed. Well, I can tell you that I every day get troll tweets against me. She said you didn't need the mask. Yeah, I said that in the second week of January 2020.
Right.
And similarly, everybody from Tony Fauci to, Scott Gottlieb, you can do the whole political gamut, has taken heat for whatever they have said about masks. So the real question is, in whose interest is it to insist that masks don't work or that they are not needed? What is the agenda behind this? Because you can certainly see why someone who is advocating for masks would want it. And it's saying, this is to protect you and to keep you from exhaling onto other people if you happen to unknowingly, be shedding virus. You don't know you're infected. So in whose interest is it to discount this, right? Mm-hmm. And you discover there's just basically two groups who stand to benefit from seeing the mask under dispute. And one is libertarians. And their number one advocate is Senator Rand Paul. And the other is economic interests who feel that this deters business. Fewer people come to their restaurant, fewer people come to their movie theater, fewer people come wherever if you impose a mask policy. In a tiny fraction, you have people who claim that somehow the mask is dangerous. And you actually have people who say that little children can't tolerate masks, that somehow it will kill them or impede their breathing, or they'll die in an asthma attack or some such thing. This is all just crazy disinformation and wacky stuff that floats out there. But you really need to ask, how do you confront the two that stand to gain from being against masks? As far as the libertarians go, that's ideology. There's nothing else there but straight out political ideology. And attacking that is very difficult because the adherents to the ideology are not going to be persuaded out of their belief system based on you saying, but in the case of economic interests, I think there are strategies, and you can see quite a body of literature on this, both in the sort of business economics literature and in social sciences, that very well speaks to what does it take to create support within the business community for difficult measures that they may not like to see. And certainly one of the arguments that could have been made much more effectively long ago is that if you don't like lockdown, this is your best companion, pal. If you didn't like your business locked down, you should be praising the mask as an alternative that allows you to keep your business open as long as you and your customers are wearing masks. But it was never really well argued. And the CDC has unfortunately appeared to vacillate all over the place. And so they are easily attacked by those who say they don't know what they're talking about and they're making it up as they go.
Yeah. Well, I have several more questions for you, but I think it's time to bring in your co-panelists. So at this time, I'd love to bring in the other panelists and ask some more targeted questions. So I will direct the questions to a specific panelist, but please feel free if others have a burning opinion that they would like to share. Please feel free to respond as well. So this first one goes to you, Jonna. So as Jaime mentioned earlier in this meeting, or in this webinar rather, your involvement in One Health. And so I was hoping that you could share with us all a little bit more about what exactly is One Health, and has the One Health model been applied to COVID-19? And if not, why not?
Sure, thanks for the question, Paul. So One Health is a holistic approach to complex problems. It recognizes the inextricable connections among human, animal, environmental, and plant health. And importantly, I think it employs a collaborative and respectful engagement approach, really welcoming all disciplines and encouraging all people's voices, especially those from marginalized communities. And I think that last part about marginalized communities has gotten even stronger during the COVID pandemic. So in preparation for any emergency, I think the best practice is to establish trusting relationships and terms of engagement in advance. And that's what One Health advocates. So in some places in the world, that happened. In fact, I was lucky enough to work with USAID for more than a decade to help that happen, advocating for engagements to prepare for disease X, even going so far as to wave the flag of threat of coronaviruses. And many countries, we worked in about 40 countries, and most of those countries responded with significant advances, including developing One Health platforms, where at least the ministries of health, agriculture, and environment came together to engage in exercises, epidemic and pandemic capacity strengthening, data sharing, trust building, all the essential elements that you need so that when an emergency strikes, you're ready and able to listen to all of the important voices that are experiencing what's happening, and also have boots on the ground or technical expertise to really contribute and make a difference in the early stages. And that's when the public health interventions can be most effective. So in places we were working like Thailand and Nepal, the teams we worked with in those countries and really all over Southeast Asia and Africa jumped in, and their One Health platforms engaged. Thailand and Nepal, I bring up as specific examples, Cambodia as well. They diagnosed the very first introduced cases of COVID into their countries because they were ready, they were trusting, they knew who to call, they knew who were coronavirus experts. They called them in, they tested, they said, yes, those folks need to be under quarantine and we need to follow their close contacts, activating public health. And in fact, in Rwanda and Tanzania and other places we work, they were able to say, hey, those people are clear. They can go about their business. We don't need to put people on lockdown. So it really, really helped. What we as a One Health community didn't do well is we did not engage up from the ministers. So we didn't engage the presidents and the prime minister's offices. And actually there's a bunch of us now are advocating that that's where these One Health platforms should live, in those offices. So they're close to the top. So where those preparations were in place, it worked really well early on. Great early successes, but those successes, unfortunately, were eclipsed once the geopolitical agendas came into play. So I believe we absolutely need One Health if we're going to employ early warning systems. So one of the important reasons we need it is that most newly recognized diseases in people are spillover events from other species. And so if we aren't looking upstream from that initial spillover event or ready to diagnose at that spillover event, because we are ignoring what's happening in the environment, we're ignoring what's happening in animal populations, we're ignoring the drivers like climate change and other things, which gets us to all of the scientific literacy and some of Laurie's important comments. If we are going to employ early warning systems, be ready to prevent or stop epidemics before they become pandemics, I think we need One Health. And I do see signs of real hope as advocates in the financial and international governance communities are now screaming for the One Health approach. I think that's good. It is the foundation for preparedness planning, but we do need to come together and build the trust in all the relationships and with all of the disciplines and communities.
Great, thank you for that. Next, Larry, speaking of trust, trust in public health in the United States is at an all-time low. While there are many reasons why it has been eroded over the last 2 years, what can be done to restore public confidence in public health institutions?
Thanks, Paul. Well, first of all, I want to welcome my friend Laurie Garrett to the left coast. It's really nice to have you here, Laurie. The tsunami, the Asian tsunami, which occurred on the 26th of December, Boxing Day, in 2004, really devastated a lot of Southeast Asia. And I was one of the many doctors who was working in refugee camps. And I expected that the salty water from the ocean spilling over into the fresh water in all the lakes, especially in Sri Lanka where I worked, that brackish water would change the characteristic of which mosquitoes survived. And I was looking for people to be worried about dengue. I was looking for that to be the predominant concern in the refugee camps. But to my surprise, everybody was reading books and articles by Laurie Garrett. And Laurie, you were writing about H5N1 at a time that I had not even heard of it. I'd worked in smallpox, worked in polio, but I didn't really understand what H5N1 meant. and that an influenza pandemic that didn't happen but could have sparked, I think, a renewed interest in pandemics. So I give the credit to Laurie for bringing this front and center. When we think about trust, Bill Foege, my mentor for many of us, says that with public will and with public trust, public health can do anything. And without public will and public trust, public health can't do anything. We were talking earlier about spillovers. Spillovers are inevitable with climate change, with species from the southern hemisphere going to the northern hemisphere, commingling their viruses, creating new variants, with droughts and famines and human migration, with more and more wild animals being eaten by people too poor to be able to afford commercial food, and more exotic wild animals at the other end of the spectrum being kept as pets by the wealthy communities. By cutting down the rainforests, cutting down forests so bats and other flying animals have no place to go, by increasing poultry industry, increasing amount of pigs all over the world. Spillovers are inevitable, and those spillovers in the early days will only be met by trust, because you won't have a vaccine. You won't have an antiviral. 6 months world record speed is not enough to stop a virus which is respiratory spread and has spilled over from an animal and has an incubation period of 1 to 4 days and R naughts in the 5, 6, 7 range. What we need at that time, and what we need all the time, is public trust, because we're going to ask people to do things which are difficult to do. We're going to ask them to believe that an odorless, invisible, tasteless virus is a reason that they must stop economic activity, that they must give up their names of their friends and engage in contact tracing. So the time to build that trust is now. One really good example of both One Health and trust is Dr. Me in Thailand, which has been working with an app that allows people to report on losses in their agriculture, in their chicken herds, and in their bovine herds, and to report them in, and in Cambodia, the 113 hotline, where people can report sick animals and sick people. That is building trust in people before there is a pandemic, and it certainly helped a great deal in making those countries, particularly Cambodia and Vietnam, the best performing countries in the world in the early pre-vaccine days, a time when that kind of trust is necessary. Now, the other kind of trust is something that is so easily squandered in our divisive politics. It couldn't happen at a more important moment than today, when we're talking about the near miss of losing our democracy, when we had a president and acolytes who were saying herd immunity was coming, that the pandemic was made up, and it was a fictional representation of democratic ideas, that the Democrats were trying to foster this. We've not really experienced that level of politicization of public health. If we don't have a base of trust, then the politicization is going to be very easy, and it's going to be quite easy to victimize public health professionals. I think all of us on this call have friends who've had death threats because they recommended masks, because they recommended vaccines, because they stood fast when it was necessary at some point in time to close down some parts of our society. We need to do that today, because this pandemic has an uncertain future. There's no one who can say whether it's going to wane or wax over the respiratory period that we have now going into the winter. There's a lot of forces in both directions right now. But the one thing for sure is it will not be the last pandemic. And it may not be the last pandemic of major consequences. Today, we need to build back the trust that we've lost, particularly in those early days when a novel zoonotic disease jumps species someplace far away. Wherever it jumps, it's going to be far away from most of the world. And we begin to rebuild trust in the public health professionals who are really putting their life on the line. And I think about how much we venerated the first responders. I'd like to say that the first responders, the very first responders, are the public health people who risked everything. Let's help them by build back the trust that has been squandered by the political process.
Thank you for that. Just to follow up, and this can be directed to you, Larry, or to any of the other panelists, given the politicization and polarization in this country, do you have any reflections on what that roadmap to regaining public trust and public confidence looks like or could look like?
Well, I think it's so intricately wound up in our political process. Another great quote from Bill Foege, he said, for so many years, for 50 years, we in public health, professors of public health, practitioners of public health, we've been saying, keep the politics out of public health. And he says now, perhaps we were completely wrong. Perhaps what we need to do is bring public health into politics so that politicians on all sides are constantly reminded of what public health is. Laurie said something brilliant. She said, the vaccines that were developed in Operation Warp Speed were not public health instruments. They were medical instruments. They were wonderful in keeping people from getting very sick and, most importantly, keeping them from getting dead. But they didn't do what the smallpox vaccine allowed us to do in the smallpox program, with the polio vaccine. We had a term called sterilizing immunity. We did not create the bar that the vaccine that we wanted to put our money in would prevent people from getting it. I do think that there's still a chance for everybody. I think there's still a chance to get nasal vaccines and oral vaccines. I hope that we do some of that. I hope the experiments in India and in China that we're seeing work out. But right now, I think what we need to do is to go back to the basics and understand that we need to have that level of trust early on if we want to have it later on. I think Tom Frieden says very often, the middle of an emergency is not a good time to start introducing yourself to your colleagues.
Right. Thank you. So next I want to direct this question to you two. What do we have to keep in mind when trying to utilize technology or digital health products to prevent the next pandemic? And specifically, how is Gilead's Global Patient Solutions thinking about how to prevent the next pandemic?
Thank you, Paul. And thank you to the Bay Area Global Health Alliance for inviting me today. It's such a distinct honor to be alongside this really distinguished group of speakers. So again, thank you. Seeing as this is hosted by the Bay Area Global Health Alliance, I think it's fitting that we speak about the promise and value of technology and the impact it can have. And that can be distinctly created from Silicon Valley and the innovative institutions that call the Bay Area home. But I also think it's really important to acknowledge that pandemics start and stop in communities. In some senses, a lot of my fellow panelists and speakers have talked about versions of this. Trust, really One Health being able to incorporate marginalized communities. Those who have worked in infectious diseases like malaria know, again, that pandemics start and stop in communities. And I believe I stole that quote from Raj Punjabi, who used to be the head of PMI, but also has a very distinguished career in community health. But now I think the whole world, to some extent, understands that concept, that by the time a case shows up at the hospital or the clinic, it's already had the chance to spread in communities. And the longer we delay, the greater the barriers to care are for our most marginalized communities, the more time we lose to deploy any number of tools. But on a positive note, pandemics also stop in communities. That's where education happens. That's where our individual and collective actions that we take, that's when they're the most preventative measures. And community health workers have been delivering that frontline care because they're the ones who are trusted, they're the ones who are embedded. And when it's done early and accessibly, community health workers are the ones that help stop pandemics and epidemics in their track. Therefore, I think the consideration that's really important when we think about the technologies and tools that should be designed is that they should be designed to enable robust community level inputs. The visions about global surveillance and real-time data, the need to consider, the signals that we're getting all over the world, I think we really need to consider the quality of data that's being aggregated for these decision makers. bad in, bad out. So really, I'm here to, advocate for, when designing these tools, to really center the community, and also think about what gets sent back to your kind of frontline heroes. It's not a one-way direction. It's technology, I hope, can kind of, enable, that circular type of positive feedback loop. And so not only is centering the community in terms of technology important for the consideration of quality assurance, again, bad in, bad out, but it also creates the linkages that need to be strengthened so that we can continually invest in where pandemics stop. And that's at the community level. It's when there's integration of data sources that compile a composite of what's happening in the community and at various levels of care. I think, again, Jonna mentioned this early on, it's about listening to all of the voices, and how does technology enable us to listen a little bit more effectively, and make decisions. So again, I'm joining you today from Gilead's Global Patient Solutions. This is a business unit dedicated to providing access to life-saving medicines for HIV, viral hepatitis, invasive fungal infections, and oncology. This particular group looks after 90 countries that make up lower middle income and middle income countries across sub-Saharan Africa, South Asia, and Southeast Asia. We partner with governments and communities to reduce the disproportionate burden of diseases in low and middle income countries. And together, we hope to contribute to strengthening the building blocks of health systems and driving private sector engagement to achieve the sustainable development goals in health and in partnership. Ultimately, our goal is to deliver meaningful impact backed up by rigorous assessment. And so in that vein, Gilead's been working to end the HIV epidemic well before the COVID pandemic. So we think about kind of this a lot. And what we learned from that experience of really battling in the HIV epidemic has proven to be really important for COVID as well as monkeypox. And we hope they'll be important for kind of, as Larry said, this isn't, and many of the speakers said, this isn't our last pandemic. What we learned from that experience is that it's critical to invest even further in our ability to strengthen community engagement, which again, to me, feels like another phrase of the trust, that public health trust, and anything can be done and nothing can be done with or without that. So we see it as critical to invest in community engagement, the health education, primary healthcare. These are tools that we've brought to the HIV fight, and I think we need to double down and invest in. And I'm not saying by any means we have the playbook for how to prevent the next pandemic. And I won't even say it comes down to a pillar of product. It's that generally, and that's normally what people know pharma for, but we do have principles guided by health equity that inform how we partner with governments, and listening to this conversation with communities and the press and the other ways we communicate, like all that has to be wrapped up so that we're picking appropriate solutions, or we're investing in appropriate solutions for different infectious disease contexts. So thank you for the question, and again, thank you for allowing me to kind of speak alongside this really distinguished panel. I've learned so much, and I'm looking forward to the rest of the conversation.
And thank you so much for offering that perspective. Aside from our earlier conversation about the vaccines, we really haven't talked about that, the private sector perspective and how the private sector fits into this broader public health ecosystem. So thank you for that. So Laurie, I want to return to you with this next question. This is a question I didn't get a chance to ask earlier, but really wanted to get your perspective on, which is why has the monkeypox or mpox seemingly come under control in the United States and Canada and Europe, and what was different with this pandemic versus COVID? And what do you think are the big take-home messages from mpox?
Well, I think it comes down to one thing, and that is gay activism. If there's any community in all of the world that gets public health, it's gay men, especially those who have gone through the darkest years of HIV. And the gay community is well organized, and the intervention necessary was pretty simple, pretty basic. There's no threat of airborne transmission of monkeypox. So first, let's say what didn't make a difference. Very, very few people in the vulnerable or targeted population have had a successful completion of the vaccine course, the initial full dose and then a booster follow-up. In fact, most people have only had a single suboptimal dosing. So I don't really think there's any reason to believe that vaccination has been a key in controlling monkeypox up to this point. What has been the key is intense organizing in the gay community and smart organizing by both state health agencies and the CDC, targeting such things as gay pride festivals, major gatherings of the LGBTQ community, and particularly over the summer, big festivals and so on, saying, hey, everybody, line up right here. We're going to test you real quick. If you're positive, we're going to get you on a vaccine. We're going to get you where you need to go really fast, do some quick contact tracing. If there was going to be a community that would understand and appreciate the threat, this was the community. And I really think the gay health leadership deserves the credit, deserves the applause. And I think this has been true in most of the world. Now, of course, when you look at the African context, you have a very different scenario. And there, I think you really have to give huge applause to the African CDC and to the WHO regional office in Brazzaville, because they've both played very aggressive roles in Africa, trying to bring monkeypox under control. But I don't think we should kid ourselves. We've seen a big decline in the incidence and prevalence of monkeypox in the United States and in Western Europe, but Nigeria is still struggling. There will continue to be, resurgent monkeypox in key parts of sub-Saharan Africa. And unless we take the whole question of the vaccine seriously and ask, does Jynneos have any data to show that it actually blocks transmission? What have we learned from those who have received the vaccine so far? And can the vaccine be improved specifically for monkeypox? Unless we go down that path and invest those dollars, we could be caught by surprise with a monkeypox outbreak that will be different and hit a different population. I think the bit of social science I would love to see done well right now. There's certainly reasons to believe it's true, but I haven't seen really convincing data yet, is the role of Grindr. Because, when the communities went on lockdown in 2020, for a lot of gay men, this was a very lonely and isolating time. And as things began to open up a bit, still some of the bar scene was still closed. A lot of the sort of in-person community gathering was closed down, but Grindr was there. So you could go online and create your avatar, your profile, and find a partner for the evening or what have you. And certainly this has played a role in the spread, not only of monkeypox, but high incidence we see of syphilis, of drug-resistant gonorrhea, chlamydia. I mean, we've had an STD explosion going on in direct reaction against, being under lockdown. And this, by the way, is not just in the gay community. We have a skyrocketing incidence of several STDs across the board. And, we've not really addressed this at all. And in the gay community, there really was a hiatus to sort of put it on hold on Grindr for a while. And I mean, I know from the New York experience, there were really aggressive campaigns carried out on Fire Island and in key places that are summer go-to spots for New York gay men. And the health departments were pretty smart. I mean, they got beyond monkeypox to talk about syphilis and talk about HIV and so on. I think the last lesson, though, that's a cautionary thing, is to consider if men were acquiring monkeypox, then they had to have been also at risk for acquiring HIV. And that means that a lot of the messaging going on around PrEP and taking, drugs to prevent HIV infection are not getting through right for the younger generation. I think that there needs to be some real public health attention to this, because it points up a vulnerability that shouldn't be there.
Thank you for that perspective. So I just have 2 more questions that I would like to actually pose to our entire group of panelists, and we can go in order from before, and I'll remind us what that order was. But the first question is, there's overwhelming consensus from experts like Jonna and others that there will be more pandemics in the future. We've talked about that a number of times during this discussion already. What are the key public health interventions that can ensure that we respond to those future threats better than we did to COVID? And why don't I start with you, Jonna?
Just an easy one. I think I'd like to start, and it's a theme. We're hearing it throughout this whole panel and from Laurie's conversation with you before that, and that is, and I'm not sure anybody studying a public health textbook will find it as strongly as we're saying it here, but it's established those trusted relationships before there's an epidemic and a pandemic, and that is key. And that is, I'm going to call that now a public health intervention, maybe others have, but it is key. Bring in the community-based organizations, give them voice, and let that listen to them and work with them. So forge those partnerships with government, with community, with scientists. And I think one of the things many of the folks on this panel and actually sponsoring this panel have been working on that, have been working on a kind of a playbook, a roadmap, if you will, to start to integrate the different sectors that were so poorly integrated or not integrated at all. So I really think it's key. It's not easy. It's hard work. You have to have a reason to keep getting together in what is the calm time, the non-epidemic time. And that's not easy because people get busy. I think we have to benefit from the amazing public spirit, human spirit that we saw that allowed us all to really, at the beginning of the pandemic, work together beautifully. As Laurie said, changes in science, people putting out their data without waiting for a publication. Those great things, that great human spirit to save each other that eroded too quickly because of lacks of trust. We need to build the trust so that doesn't happen again.
Great, thank you. Larry, what's your perspective on key public health interventions?
Well, I'd like to talk a little bit about monkeypox as sort of a case study right now. I think one of the things that public health people have to do is not only be scientists, but we have to be futurists. We have to look around the corner, and we have to look at things that are of low probability, but highly consequential. So monkeypox is an orthopox virus. It's a DNA virus. It, like smallpox, is something that we wouldn't normally expect to have very many mutations and very many variants, but that's not what we're seeing. We're seeing more variants than we expected. We're also seeing it as an epizootic as well as an epidemic. There are well more than 24 animals that have already been infected with monkeypox. That shouldn't be a surprise, because monkeypox is not a disease of monkeys, not a disease of gay men, not a disease of women. It is a disease primarily of rodents, historically. So, and the last outbreak before this in the United States was traced to giant Gambian rodents who were shipped as pets into the United States and cohabitated with prairie dogs.
Prairie dogs, yeah.
Prairie dogs, and spread it in Minneapolis and Minnesota. So it is more likely than not that there will be a spillover, spillback, spillover phenomenon if we don't stop monkeypox early. And there's the problem. It's a low probability that each one of those things will happen, but in the aggregate, it's something we have to take very seriously. So when we look at each of these diseases individually, they'll have their different characteristics, but as somebody who spent a decade trying to eradicate smallpox, I have to tell you that the one argument that was made against WHO from even beginning to start smallpox, when Professor Zhdanov, a Russian epidemiologist and Minister of Health, proposed that the world get together and eradicate smallpox, the major objection was, what about monkeypox? If you eradicate smallpox and you stop vaccinating, will monkeypox become ascendant and occupy the ecological niche of smallpox? We eradicated smallpox, thank God. We stopped vaccinating. And that's the main reason I think that monkeypox incidence has increased, because the protection coverage of obligatory, mandatory vaccination with smallpox, the vaccine of which stops monkeypox as well, was lifted. I think right now we have more reason than usual to keep this outbreak of monkeypox under control, and to go back to Nigeria and to go back to the Congo and give them the aid that they need to help put monkeypox back in that bottle. Because if it continues infecting animals all over the world, every time that happens, it increases the risk that we will find an orthopox virus in the urban rats of Tokyo, Paris, New York, and that's a frightening phenomenon.
Yeah.
Yeah, I think that's a really important perspective. I think my concern is with framing it around, we need to have a perspective on what has small probability but huge consequence, is getting the political buy-in or the inspiring the vision among our politicians and leaders to invest in those circumstances or scenarios that have low probability but huge consequence. Thu, what are your thoughts on effective public health interventions?
I guess I'll use this platform just to kind of put my chips in for investing in community health workers. I think you heard this in my responses before, and trying to thread the line between some of the responses of my co-panelists. Community health workers are a fragmented workforce, but we rely on them so heavily, in times of emergency and in times of long burning epidemics and pandemics. And so the more we can invest and kind of reduce that fragmentation and fill the gap, I think the better off we'll all be. And this is a cause that I also feel like, has some kind of political momentum. I hope, the Africa CDC has put out the call for 2 million more healthcare workers, and with numbers behind how many we need for community healthcare workers to meet these gaps and so forth. And so that's leadership that I can't applaud enough. And in addition, we're seeing kind of the big financing institutions like the Global Fund and some of the bilaterals from the US being able to support that health system strengthening work that community healthcare workers are asked to do, to deliver our rapid diagnostic tests, to do kind of community engagement. So again, it just feels like this is a moment to really elevate them and elevate kind of the cohort as a public health platform, but really ask for true investment in it. They're not tools to be called upon during times of emergencies. They're foundations that we have to build. Again, the thoughts of, don't introduce yourself when it's already a pandemic. That's not the way we're going to do this. And in some senses, I really see community health workers and the ability to have strong cohorts of them as kind of the factor of how we build trust. What is that kind of interface between a day-to-day person who doesn't think about themselves as a patient, but needs to be able to interact with healthcare systems quickly and effectively. So thank you. Thank you for the opportunity.
Very well said. All right, Laurie, back to you. What are your thoughts on effective public health interventions?
Thanks, Paul. I want to first, before I answer your question, if I may, I want to just shout out to both Larry and Jaime, because I have known both of them and admired their work for so long that I don't think either of us want to put a timeline on it for our own dignity, but it's been a long time. And Larry and I worked together on the movie Contagion. And that was, I think, one of the biggest contributions both of us have been able to make, because I can't tell you how many people have told me that when they first heard about the epidemic in Wuhan, they ran to Netflix to watch Contagion and get a sense of what we were in for. And it's kind of remarkable how much proved to be accurate. As far as the toolkit goes, I always like to say Herman Biggs was the first guy to really say, here's germ theory, here's microscopes, here's how to grow bacteria in an agar dish. Let's make these tools the basis of urban public health system. And so the New York City health system was originally set up, more than 120 years ago, based on germ theory and microscopy. Now we're in the 21st century. We can go way past that. We don't have to rely on coliform assays of wastewater and nothing more than fever checks. We can go all the way to something much bigger and bolder, and it should be our aspiration to do so. We should go from the germ theory era of public health to the genomic era of public health, and look at the great successes people are having doing wastewater metagenomics screening, and what this would mean integrating the One Health approach in with public health writ large. And so, I think the aspirational target is to take things like the Oxford Nanopore Minion or other very small point of care, rapid genomically based diagnostic tools that can help you to know what's in your environment and relay it immediately through a telephone or a laptop to a cloud site or to an analytical point. We should aspire to something that is so cheap, so simple, so easy to use that it's like a ballpoint pen dipped into some water and then plugged into a phone. And you don't need to be so skilled that you even understand what DNA is. So our whole frontline community work team that's been described here, such as the 1 million people involved in trying to eradicate polio, many of whom are semi-literate, can easily be frontline workers out there testing wastewater, testing in animal husbandry sites, testing effluent in rivers, testing hospital waste, testing in school systems, all manner of places to understand at the microbial level, what does our environment look like? What's going on in our ecosphere? Is there anything there that we need to be alarmed about? Is, as Larry warned, monkeypox taking a turn? Or I would add, are we looking at XDR, multiple drug resistant plasmids out there that are showing up in our wastewater, indicating that upstream amoxicillin ain't working no more. Penicillin ain't working no more. What are you going to do? How do you track this down? And I would go even further and say, we won't be able to do this at the scale that we can and should do it if we only rely on people with masters and PhDs in sciences. This has to be community science. This has to be every citizen can be engaged. And by the way, that makes then epidemics or the threat of outbreaks automatically transparent, because any 13-year-old can take their testing device and go out and find something, even if the government doesn't want the world to know about it. And if you begin to create a genuinely interactive, transparent, web-based method for sending and receiving information about perturbations in the ecosphere that may be indicators of climate change activity that's dangerous, that's fundamentally changing the basic biology of an ecosphere, or pathogens or drug resistance factors, if this becomes transparent and exposed to the world, then it changes the whole nature of public health. It changes the whole nature of trust, and it changes the whole nature of accountability of government.
Thank you. I think that's a really key perspective there that ties it all back together, everything that we've talked about throughout this webinar so far about trust and community involvement and transparency. So I think that's actually a great place to end off my monopolization of the questions posed to the panel. And I think now we can open it up to questions from the audience. So just looking at my list, the first one that comes up is actually for you, Jonna. And it is, this is a question from Jeremy. How can we use the current focus on climate change to better understand the impact of climate change on pandemics to better prepare ourselves?
Well, I think, and thanks to Jeremy for that. I think the important thing to think about is when we're talking, we've been spending this whole thing talking about emerging health threats. Well, climate change and emerging health threats are really inextricably linked. So we're one and the same. We humans cause climate change and are putting ourselves at risk for these emerging health threats. Viruses aren't leaping out at us. The hosts of those viruses, like bats, are not flying down and trying to get us and infect us with their viruses. We put ourselves at risk by our behaviors. So if we think of the world a little bit differently, that we are not ruling it, but we are a part of it, and that we need to harmoniously live with the planet, we start to see that we are having such a huge impact on all of these things. Now, I can give you lots of examples about how climate change is driving pathogens, for example, into the Pacific Ocean that have never been seen, and infecting hosts, including people and other things here that had never been seen here, right? But we can see that it is not just a change in the distribution of the vectors, for example, the mosquitoes and other things that carry diseases. It's how we are using the planet and abusing the planet. And we need to really reduce our footprint or walk more gently on this planet.
Thank you. So the next question is primarily for Larry, but open to everyone. This is from Lisa Foster. How is the public health community thinking about antibiotic resistance, given the fact that so few people have had the full course of treatment? Is AMR something we need to be digging into more urgently?
Thank you, Lisa. I think antibiotic resistant organisms are one of the top 3 or 4 pandemic risks that we face in the next 20, 30 years. It's almost like a reunion of old friends. It's cholera, it's tuberculosis, it's the bacterial diseases that have caused the major pandemics throughout world history. We forget that the Black Death wasn't a virus, it was a bacteria. If we no longer have the tools that kept bacterial diseases in check at the individual level, the community level, the outbreak level, the epidemic and pandemic level, they surely will come back again. And I think that the pharmaceutical companies have let us down. They're not good at looking around the corner and investing in what could come next. Perhaps that's another area in which public health can exercise our supervision and see around the corner and become futurists and put the antibiotic resistant bacterial pandemics front and center when we talk about pandemic risk.
Thank you. This next question is for Laurie, back to you. And this is from Eric Gooseby. Can you give us your thoughts on how the press, in all its forms, helped or detracted from strengthening the COVID response, and what is responsible for correction?
Ooh-wee, nice little one, Eric. As always, you throw me the big curveballs. Look, first of all, before I say an actual direct answer to the question, I have to background people, because outside of the world of journalism and the profession itself, most people are unaware of how radically the economics of journalism has changed. Very few journalists are making much money. A lot of the reporters whose work you may admire are actually have to have another job because journalism pays so poorly now. And the number of institutions that have sufficient financial wherewithal to subsidize a serious range of journalist talent and support investigative and foreign reporting has shrunk. I mean, it's, you know, if it weren't for Jeff Bezos, the Washington Post would probably have died by now. And another billionaire is responsible for keeping the LA Times alive. And as you can see, fewer and fewer people are even looking at network news. And more people are getting their information in a sort of vague osmotic process that they can't even really describe to you. You know, if you ask somebody, where did you hear that Kim Kardashian has a cure for COVID? Where did you hear that? Oh, I don't know. I was on the internet and I think it was Instagram somewhere, or maybe it was TikTok. I don't remember, right? So we're now in a world where the kind of sophisticated journalism that people in my age group were accustomed to is increasingly difficult, even though the talent pool is there, and is grossly under-resourced. And the kind of pseudo-journalism that most people are now exposed to, that is just factoids thrown out and amid phony stuff and trolling and counterclaims on social media, has come to dominate the landscape. So Eric, I mean, you know, you and I go back to the days when it was all about how do we convince people that Peter Duesberg is a source of disinformation. And no, HIV is not a harmless chunk of RNA, it's an actual killer virus. And yes, AZT is part of an armamentarium that will effectively treat people who are infected with this virus. You know, that was a fight that could be waged in a reasonable time span and with resources that were readily available at that time. But now we are seeing a situation where the president of the United States can actually say, you know, hydroxychloroquine. And we still see people going to the doctor's office 2 years later demanding hydroxychloroquine. Somebody can say ivermectin, and we still have people going and demanding ivermectin to treat their COVID infection. And I think we're at a juncture where it's really not possible to quote unquote control the message. As I said in our opening discussion, Paul, I said, look, we needed to get ahead of this. And I told the Secretary General way back in April 2020, this was going to happen, that you had to get ahead of it. There had to be clear messaging. And in fact, I told the WHO folks that I thought choosing the acronym COVID to describe the virus was a huge mistake because it sounded like covert. It sounded like a CIA acronym, COVID. There were a lot of other possible ways you could have named this virus that wouldn't have instantly gone into paranoiaville. I don't think that there is a simple answer to your question because it overlaps with the general answer to the crisis of information and the crisis of journalism, not just in the United States, but worldwide. And I would just give as a side note, you know, if you want to see how effectively some institutions and governments are controlling the message, just sit down with Google Translator and spend a couple hours trying to monitor Russian media reports about Ukraine.
Before we move on to the next question, just a quick follow-up. Did you have a suggestion for the WHO on a better name for what is now known as COVID?
Oh, I thought there were a lot of possibilities. And it was already at that time being called the Wuhan virus. We had a long historic tradition of naming viruses after the river that was the closest to wherever it was first spotted. So, you know, the Machupo virus, the Nyong or Ebola, they were all named after geography, basically. But WHO didn't want to have any name that would tick off the Chinese because it was already a huge tense situation with the Chinese government. So I didn't have a really great idea of an alternative name that I was pushing. I just was saying, look, let's not make it sound like a Hollywood secret spy agency.
Thanks. Thanks for satisfying my curiosity right there. So maybe one more, and this is for all the panelists. In the prediction vein, Randy Newcomb of the Omidyar, hopefully I'm pronouncing that correctly, group asks, from the perspective of probabilities, can you offer a probability of a respiratory-borne pandemic over the next 5 years or 10 years? And Jesse A. Controlla asks, when do you predict will the big mega epidemic hit?
Well, I'll jump in because fools jump in where angels dead to. But Randy's a friend of mine. Hi, Randy. You know, a group of us have just had a 6-month study section trying to predict or analyze what the most likely agents would be that would cause the next big one. And I'm going to define big one in just a moment. We've actually had half a dozen other pandemics in this century between the Spanish flu, the 1918 H1N1 flu, and COVID-19, SARS-CoV-2. But we don't think of those as being the disruptive pandemics that we've had before. And we should just look at what those two are. The agents of the most disruptive pandemics were viral spillovers. They became respiratory diseases, and they're only part of two families, influenza and coronavirus. I think those two families still are the most likely causes of the next big one, the one that can bring humanity to its knees the way we've just seen in the last 3 years. I put right up there pretty close, though, the vector-borne diseases that have been made more likely to spread as a consequence of climate change. The Anopheles mosquito is now able to breed at higher altitudes and wider latitudes. Over 1 billion people have now been brought under the control and at risk of malaria because of climate change. So I think you have to look at the vector-borne diseases, the arboviruses as a family. And the next one I would put in, as we said earlier, all the antibiotic-resistant diseases, the diseases that we've thrown away, thinking of it as Dickinsonian or something of that nature, plague, tuberculosis, cholera. If we don't solve the problem of antibiotics running out of steam and all of the coffers are empty, and anyone you talk to in pharma will tell you that they just don't have a big bench in new antibiotics. So those are the 4 classes that I worry about. And then, of course, there's always the curveball. And WHO has been having an exercise for the past 6 months called Pathogen X, trying to brainstorm what that curveball could be. I think those 5 general categories are the kinds of things that I would expect. And as for the date, nobody can tell you that, Randy. It certainly is not going to be 100 years between great pandemics as has been before. In fact, I think it's a kind of a problem because it's almost exactly 100 years between 2019 and 1918, and people may think of this as like a 100-year flood. Well, 100-year floods are no longer every 100 years; they're every decade. And I'm afraid we'll see the same kind of cadence for pandemics if we don't take it seriously. And so those are the things that I would say. Sooner than you think, most likely to come from some of those 5 general families, most likely to be respiratory disease, unless it's an antibiotic-resistant organism.
Got it.
But I'm open to everybody else. I'm sure everybody will have a favorite.
Well, I would jump in and say a couple of quick things. First, I'm really surprised you didn't mention HIV, Larry. That was the 2nd largest pandemic of the last 100 years. It's ongoing. It's never been stopped. It's never been cured. There is no vaccine. It is a 100% failure. And it has involved the largest transference of wealth from the northern wealthy nations to the nations in need that we've ever seen in global health. And that's ongoing. And Eric Gooseby, who's on the call, used to head that up at PEPFAR. So, and that leads me to note that we had the Zika crisis of 2015, 2016. And one of the things that made that such a significant crisis was an early warning that now we see with monkeypox, and that is, here's a virus that normally was only transmitted by mosquito to human, and it turned into a sexually transmitted disease and a mother to child transmissible disease. And the worst outcomes of it were all as a result of mother to child transmission or fetal transmission. Monkeypox, here's a disease that, you know, nowhere did anybody been talking about sexual transmission. And that's basically what we were totally looking at. We're increasingly looking at sexual transmission of Ebola. And that is becoming, you know, more and more evidence even of semen reservoir with the individual, the male, long since healed and yet capable months later of transmitting virus to a sexual partner. These are all surprises. And I think these are surprises of pre-existing pathogens that find new settings and new modes of transmission because of how we as human beings live on this earth, not because they changed. There's no big mutation that says now I'm a sexually transmitted virus. We humans are giving them, aiding and abetting. I always say we aid and abet the microbes. And in that vein, I would go the next step and say, the last of Larry's categories is the one that I would jump on. I don't think that we have much more than a rudimentary understanding, a hint of a glimpse of an understanding of the microbial world that is responsible for all life on this planet. The bottom of the food chain, the bottom of the chemical chain, the producers of the essence of life that we depend upon, and 90% of the cells inside of our own sac that we call the human body. And this microbial world is changing, and it's changing really fast. You know, in like 2 human generations, the diversity of the human microbiome has been depleted by roughly 50%, depending on whose database you want to look at. And when I go out, particularly in the Arctic, I've spent time recently in Greenland, Svalbard, the Arctic regions of Scandinavia, and looking at what microbiome evidence there is for radical changes in these ecologies, and it's overwhelming. If we're so naive as to think that the textbook of life that we've been working with to assess threat, you know, for the last 100 years is stable, and that we can draw calculus based on that textbook, then, you know, we're fools. We're total fools, because the textbook is being rewritten right now in the tree of life. And I just give the example that, you know, we haven't mentioned any point today, but nobody said fungus or fungi. But, you know, that huge COVID die-off in India, a big piece of that was an invasive black fungus that was a real opportunistic infection that just swarmed the lungs of people who already had their immune system suppressed by a COVID infection. And, you know, we have to remember that the first big killer of people with HIV was a fungal disease. And so when you look at the list and think of the great surprises of horrors yet to be, number one, yes, there will be. And it's not one, it's not two, it's a lot. Number two, will there be inequity in the response? Yes, of course, because that's what jerks our species is or are. And three, you know, will it be a surprise? And will we find that our toolkit is lacking in the essentials to counteract it? Of course. And then I would just finally say that's all the more reason why I think we have to metagenomically know our world now, figure out what our baseline is, so that we can look at any given ecology rapidly with quick turnaround sequencing analysis and say, it's changing. All of a sudden, this microbial population is surging. All of a sudden, these weird genetic bits are being found that seem to connote resistance to antibiotics or antifungals or what have you. So I would just say planet Earth hasn't been done with us yet. And there may now be 8 billion of us. And we may be bouncing off each other like ping pong balls and thereby spreading microbes like crazy. But whatever our toolkit is, we're not ready.
Paul, if you let me,
So
could I just make a comment on Laurie's excellent exegesis? And this is why, Laurie, you have to write your next book, because you've comprehensively covered it. The only thing I would add is that in order for a pandemic to occur, it doesn't take very much. In order for a pandemic to bring humanity to its knees, it has to have the element of speed. And when you have long incubation periods, and we debated HIVs extensively in this little group because it's a pandemic. Nobody wants to call it a pandemic. People want to think of it just as Reagan dismissed it, continually dismissing it. And I sure hope that we never do that. It's one of the worst diseases in human history. But a pandemic that brings the world to its knees has a velocity quite unlike anything else. And that's the only other comment that I would make in what you said. In all the things that you said, if we put another screen on it, which is which one will destroy the economy, which one will put people at war with each other and sever the bounds of trust, speed is something that we need to take account of.
Good point.
If I can just interject here, I think both of your perspectives are incredibly informative and also sobering, but very important for us all to think long and hard about. But in the last few minutes of this webinar, I'd like to pivot to a point of optimism for our audience. And in this same line of questioning about thinking about future pandemics, just a quick rapid fire among the panelists. What's the one thing that you are optimistic about when you think about the future of pandemics? And why don't we start with you, Larry?
Well, in the United States, I'm optimistic about a few states that are trying to get it right. I think California and Gavin Newsom are really engaged in a process of trying to think through what the public health system of the 21st century could be as a model for other states and a model for the rest of the world. And I applaud that effort. We've been let down by our federal government. I think we've been let down by the global organizations that we love. Many of us have worked for WHO and have a love-hate relationship with WHO. We need to fix, strengthen, fund WHO if we want to get any kind of creativity out of that wonderful old organization that has still let us down. But the states in the United States, and then I would say there's 24 countries that are members of CORDS, Coordinating Organizations for Regional Disease Surveillance. They use participatory surveillance, point-of-care diagnostics. We should be so good as they are in the United States, and I'd feel a lot more confident going forward.
What about you, Jonna?
Well,
what are you optimistic about?
It's hard. Just to be honest, I'm optimistic about the human spirit and desire to survive on this planet. And I think that if that can drive us to be collaborative and to be open and use the technology that we have, I'm optimistic. We have the technology to know all the health threats that are out there. So I'm optimistic about that, but we can't fatigue. And I'm seeing a lot of our agencies and international organizations going, oh, just need to get back to what we were doing before. And if we let our human coping mechanism allow us to forget and go back, we're just sitting ducks. So we have to take that positive spirit and move forward.
Thank you. What about you two? What are you optimistic about?
I guess I'll say I'm optimistic about the interdisciplinary nature in which I think we're starting to approach some of these questions. And I think that's really been exemplified by this convening today, that we've been talking about this from an influencer, social media, scientific writing perspective, not just a medical perspective. And I've had the honor to bring in community and implementation science perspectives as well. So I think the ability for us to continue to approach this from a multidisciplinary, intersectoral kind of point of view is what gives me hope. And just even hearing that last question of predict the next kind of big pandemic disease, we got a multitude of answers. We weren't allowing ourselves to be put into a box. And if I were to enter the chat for that as well, I'd say we'd have to look at the social determinants. It's not about picking the transmission or when, it's also talking about where are we allowing inequity to thrive? And that's probably going to be a big determinant of what the next pandemic that brings us to our knees. And it's really refreshing is the wrong word, but it's incredibly humbling to be part of this discussion and see, these perspectives coming together. So again, thank you.
Thank you for that. Laurie, I'll give you the last word on optimism.
Well, I'll confess that it's very hard to be optimistic. And certainly most of the world leadership gives little reason for hopefulness and optimism. And the UN system is itself no longer really capable of meeting 21st century challenges, primarily because of blockages at the Security Council level by China and Russia. But I think if I look for optimism on the global stage right now, the one thing that stands out is that by at least one estimate, this pandemic has cost the world economy $16 trillion. Some would put it a little higher, some a little lower. And of course, it's not over yet. And it certainly is responsible. And then with an addition of the Ukraine war atop it, for tremendous disruption of the global economy. And you would say, why would that be a source of optimism? I think that a lot of the corporate world, a lot of the business world, and certainly the academic economics world that poo-pooed the potential impact of a pandemic and downplayed the consequences are now thinking very differently. I remember when Larry Summers, former Treasury Secretary, former World Bank, et cetera, and Dean Jameson of the World Bank co-authored their pandemic guesstimate and put the figure at around $100 billion for what it would cost the world economy if we had a flu pandemic. And even then I was saying 100 billion. I mean, come on, that's chump change. I'm sure if somebody put Larry's feet to the fire today, he would be talking in the trillions. So the whole kind of economic opposition to spending on pandemics has been eroded in many quarters. It continues to exist and to be a real obstacle to public health when you talk about small businesses for whom the bottom line is immediately harmed by measures taken by public health to control an outbreak and that don't have enough, the equity to be able to ride a wave for 6 months or 9 months. So we've all seen the boarded up former businesses all over our communities, and many of them will never come back again. But what makes me hopeful is seeing statements now out of the International Monetary Fund, out of Morgan Stanley, Goldman Sachs, all the big, financial players on the planet, the World Bank, they're all recognizing that the two things that really challenge and are the major disruptive forces of the world economy are climate change and pandemics. And those two were never even on the list 10 years ago. So at least there's that. Do I have optimism that political leadership is similarly wisening up? No, I don't. I think it will continue. Larry mentioned Gavin Newsom. That's a no-brainer, right? It's blue state California with the very blue governor. But if we look on the global stage, it's a struggle to identify leaders who really are thinking of this problem at the scale it merits. You can identify some like Jacinda in New Zealand and say she took some smart steps in New Zealand, but that's different from saying which world leaders sitting on gigantic economies are really imagining how we get to the point where humanity isn't constantly lethally challenged by human to human transmitted microbes. And on that, I have no optimism except to hope that the great, powerful financial interests of the world are able to exert a little pressure, a little, shake up that at least moves the needle.
Well, thank you. Thank you to all the panelists. I'm sure I speak on behalf of everyone here in attendance that this has been really illuminating to hear your differing but also converging perspectives when it comes to pandemic threats and how best we can prepare for it, and also how we can just be better stewards of the earth and in preparation for these pandemic threats, as well as just better community members. So with that, I am going to turn it over to my colleague, Mary Pittman, for closing remarks. Thank you.
I would be a fool to try to summarize the conversation that has gone on today. It has been tremendous, and I thank all of the panelists, all of the respondents. Laurie, you've hit a home run again, making us have a hard time sleeping at night. One of my takeaways is that, as a society, we like certainty and simplicity, and our memories are short. So having these kinds of conversations, and your writings, Laurie, and all of the work that is contributing to allowing us to really understand that pandemics and climate change are not simple, they're not certain, and we have to have a longer memory to make sure that we're able to intervene. So on behalf of the Bay Area Global Health Alliance, the Public Health Institute, and also UCSF, this has been tremendous. I think it's teed up so many issues that we need to plan on having a follow-up and follow some of the threads of the conversation we've had today a little bit further. And Laurie, I echo the Larry Brilliant's suggestion that you start working on your new book if you haven't already. So thank you to all of the questions from the audience as well. They're fantastic. And I think I'll close at that and thank everyone for participating today.